So, good afternoon. It is a pleasure for me to be here among friends. And for us endocrinologists, it is a great pleasure to talk about PTH. For decades, we looked into chronic hypo-PT as an outlier in endocrinology. It was the only hormone that we have not been able to replace, and a lot has changed since in 1852 Richard Owen identified the parathyroids in rhinos, and 1880 Ivan Sandstrom, I'm looking to Jens, a person from Scandinavia, identified in humans. So we relied heavily on not a replacement but a compensation. We relied on calcium and activated vitamin D, but we were not able to replace properly the hormone, so we were trading the avoidance of hypocalcemia by increasing the risk of chronic kidney disease, nephrocalcinosis, and so on, so on, so on. So, as I said, it is for me a pleasure to be here in this symposium called Replacing the Missing Hormone, Redefining Care in Chronic Hypoparathyroidism, and we will have the opportunity to hear Professor Neil Gittos, a full professor of endocrinology from Birmingham. We will have also the pleasure to hear next Elena Tsurdi, assistant professor of endocrinology from the University of Dresden, and this session will be lively discussed by, as you all know, Professor Ana Paula Barbosa from the University of Lisbon and Professor Miguel Melo from the University of Coimbra. So for now, I will leave the stage for Neil, that will talk about translation of guidelines into clinical practice. Neil, stage is yours, please.
Thank you, Luis, and good afternoon, everybody. Thank you for the invitation to participate in this session, which will be reviewing hypoparathyroidism, particularly from the perspective of the recently published guideline in the European Journal of Endocrinology, published at the end of last year. So these are my disclosures, and I'm going to start by saying that not all guidelines are equal. A lot of guidelines are in circulation, and there is an element of guideline fatigue. If we talk to the non-specialists, there are guidelines for everything. But my point around not all guidelines are equal is that some guidelines are based on aspirations, but guidelines have to be deliverable. And when we think back to the previous guideline in hypoparathyroidism from a European perspective in 2015, then the sub-slide on the right that I'm demonstrating is some data from a specialized center in Europe trying to achieve those parameters that the guidelines recommended for hypoparathyroidism. And despite having that great expertise, with the tools that were in the bag at the time to deliver those parameters to represent optimal care, only in 2/3 of patients could we achieve those. So in other words, having a guideline that is too aspirational results in futility from the user to say, why am I trying to do this? Because I simply can't. So I think the relevance of the current guideline is that we are at a point in time where hopefully we're moving towards having that tool in the bag. And as Luis says, you know, we've worked around replacing the hormone until now, and hopefully we're entering the era with more readily available access to PTH replacement therapy so that these targets that we recognize representing high quality care can be achieved. So a little bit of history here. Slightly before, a good way before I became involved in this area, the use of high doses of native or plain vitamin D were used in mega doses to try to achieve a reasonable control of hypoparathyroidism, perhaps up to 200,000 international units daily of vitamin D2 or D3 with some calcium. And the era that we're in still, I think in most nations, is using a combination of calcium and active vitamin D to try to achieve these targets. But we're just on that threshold of moving forward into the PTH replacement era. So the algorithm on the right that probably projects, it's too small to see on this screen, but it was a cause for many hours of sleepless nights amongst many of us to try to ensure that this algorithm, and we all know the best guidelines in the world, they can be 50, 60, 150 pages long. People don't read them. Some people might read a part of them, but what they will do is to look at the algorithm that tells me what should I do with my patients. So on here, as I go through my talk, I'm going to explode various sections of them and to talk you through how the guidelines apply to clinical practice. I think the refreshing part of the guideline is that it's not just about endocrinologists. We like our numbers, looking at numbers and saying we're doing a good job. It puts the patient at the center of managing hypoparathyroidism in a very holistic way. The one point that's highlighted on this slide is quality of life. A difficult parameter. How do we measure it? How frequently? Is it part of standard practice? But we all know if we see enough patients with hypoparathyroidism, many of them, despite having perhaps occasionally reasonable biochemistry, don't feel very well at all. But we should be aiming to reduce symptoms of hypocalcemia, the typical neuromuscular issues that we see, the neuromuscular hyperexcitability, and maintain calcium in the lower part of the reference range or even marginally below the reference range, and try to avoid those long-term negative outcomes like skeletal and renal outcomes. So as I just move through that guideline, I'm going to demonstrate that the section with the blue box around it is primarily around treatment targets using conventional therapies. The bottom box is around monitoring the condition, and the box on the right that I've highlighted is how should we think about accessing PTH replacement therapy? What are the parameters? So let's just look at this in a little bit of detail, starting at the top around the diagnosis. There is now uniformity about what we mean by chronic hypoparathyroidism, and that is hypoparathyroidism with low calcium and either undetectable or inappropriately normal PTH that's been present for 12 months. So there is alignment now with other guidelines. We say to consider that diagnosis, as I say, with that biochemical signature that I've mentioned. And also, we should be having far less patients in our clinic that we label as idiopathic hypoparathyroidism. We should be taking the effort to work out the underlying cause. So family history testing, genetic testing, because we are moving towards the era where we can have more personalized medicine to think about drugs that are applicable to potentially even subtypes of hypoparathyroidism. We move on to talk about what parameters we should think about with using, at the moment I'm talking about conventional therapy, and we say to treat all patients with chronic hypoparathyroidism who have symptoms, who have a biochemistry recognizing a blood calcium below 2 millimoles per liter, and even in patients who have substantial abnormal biochemistry who say, I have no symptoms, it is warranted to treat those patients, because a lot of the hypoparathyroidism can be present for many months or even years, and people accommodate to their symptoms, and often when you introduce therapy, they may notice a step improvement in that symptomatology. So what about initiating conventional therapy? So the first part of the guideline is around conventional therapy. It does have a role in clinical practice. We talk about the use of active vitamin D and calcium. And we try to use these products to achieve the target of a calcium towards the lower end of the reference range while allowing the patient to be symptom-free from a hypocalcemia perspective. I think what's a little bit more transparent in our guideline as well is the use of calcium supplements. I would propose that we don't try hard enough with active vitamin D to try to get the best value from active vitamin D, and we rely too much upon high doses of calcium, which patients don't like, probably don't take, causes unpleasant side effects, so we should be optimizing our active vitamin D. And in the guideline, it will show there, if you look at the 3.4.2, there's the use of calcium supplements if calcium levels in the target range cannot be achieved by treatment with active vitamin D. So that is your primary player to try to achieve that endpoint of achieving acceptable levels of calcium. So it's not necessary that every patient needs to take calcium supplements. Talk to your patient about calcium in the diet, because so many occasions I'll be referred patients from the surgeons on 6 grams of calcium, allegedly, but on the recognition that the gut is only capable of handling around about 500 milligrams of supplemental calcium in one dose. So if you are using higher doses, spread it through the day. If we move on to talk about trying to achieve the initial primary targets of patient with no symptoms of a low calcium and calcium towards the lower part of the reference range, ideally their symptomatology is moving in parallel to that from a quality of life perspective. We can titrate the calcium and vitamin D to try to achieve that. That's our primary target. And then the box on the right at the top that's got a loop in it, sometimes people have asked me, how many times do we go around the loop? Clinical judgment is the answer. We didn't put a 1 or a 2 or a 3 or a 17 because that applies to the patient that you're dealing with. It would be sensible to think about 2 or 3 or 4 times going through this loop to optimize, but you soon know when you manage patients that this is going nowhere. And if it's going nowhere, what I'll move on to and what the guideline moves on to is, what do we do with these patients? We consider PTH replacement therapy, but I'll come on to that later. So if your primary endpoints are achieved, you should be thinking about the longer term, about the kidneys, about the skeleton. So we would be aiming to have a 24-hour urine calcium within the reference range. Easier said than done with conventional therapy, but that should be a target. Aim for a phosphate within the reference range, aim for magnesium in the reference range, and something that I don't think is universally accepted in practice is to try to have a 25 hydroxy vitamin D or a total vitamin D at a level of 75 nanomoles per litre, in addition to giving active vitamin D, in addition to. So how do you get there? How do you try to optimize these secondary targets? So within the guideline, I think the guideline is very practically relevant. It gives you tips and tricks as to how to achieve things. So around hypercalciuria, if you have a patient that has a high salt intake in their diet, try to reduce that salt intake. You can manipulate the urine calcium through changing the calcium and vitamin D that you're taking as well, but often the expense is that the blood calcium will fall, so you may make your patient symptomatic. So you get this vicious cycle of you're improving one thing, but at the cost of another. Thiazide diuretics are in the mix with hypercalciuria, but again, I think most of us, our clinical practice is that they do not make the problem go away. It's often not that straightforward, and then you sometimes introduce electrolyte problems or blood pressure problems, so it's sensible to try, but may not give you the answer. Hyperphosphatemia is a big issue in managing these patients with conventional therapy. Try to introduce a phosphate-restricted diet. It's a pretty miserable diet if you can achieve that, actually. And again, if you're using calcium supplements, calcium can bind phosphate in the gut, so that can help reduce phosphate absorption as well. But if you can't control the hyperphosphatemia, if you can't control the hypomagnesemia with supplements, the latter with supplements, then that again is an indication for PTH replacement therapy. And as I've mentioned, the plain vitamin D dosing to achieve a target level of 75 nanomoles per litre. And the box demonstrates a loop again. My response would be to any question, how many times do I go around that loop, is it's clinical judgment, it's clinical practice. You know your patient, you have to feel your way. But don't stay within that loop if you have access to PTH replacement therapy. There is now a way out, at least in countries where PTH replacement therapy is available. What about monitoring patients? If you've managed to achieve primary and secondary targets, we should be thinking about making sure that the biochemistry is appropriate. And I think what is new and fresh to be clearly between the eyes in this guideline is to check PTH levels once a year. There was a lot of debate about this amongst the guideline group because parathyroid glands can wake up after a long period of time beyond that 12 months. So you may have chronic hypoparathyroidism, but there have been cases reported at about 15, 16 years of chronic hypoparathyroidism where parathyroid function resumes. So if you keep the calcium towards the lower end of the reference range, it optimizes the chance of the parathyroids waking up. So to check that level once a year, because great if you can stop therapy. We should be looking at renal function, calcium, phosphate, and magnesium, perhaps every 3 to 6 months, according to how stable the patient is. And also from measuring 24-hour urine. Patients don't like it, we don't like it, but actually it's a really helpful test in terms of doing the best we can to ensure that we minimize the risk of renal dysfunction in years to come. What is different as well in this guideline is that we recommend no routine use of imaging of the renal tract. Not routine. That doesn't mean to say don't image the renal tract. So if there are situations, if somebody has a stepwise deterioration in renal function, they have symptoms suggestive of stone disease, then of course do clinically the right thing. But there is no absolute requirement to, every year or two, put somebody through an ultrasound or a CT-KUB. And similarly with DEXA scans, we know that if you perform a DEXA scan, you'll end up with a result that could be misleading. Bone density may be high and you think, great, this person is not at risk of fracture, but that's not telling us the story. In a way, DEXA doesn't really tell us about bone quality within hypoparathyroidism. So we recommend that DEXA should be used in the context of the general population, not as a specific to do with hypoparathyroidism. And now to move on to the area that is particularly new, and this is the only guideline that addresses PTH replacement therapy. What are the parameters to access PTH replacement therapy? You'll remember that the blue panels that I've spoken about around primary and secondary targets, if via looping around for a small number of occasions you can't achieve those, then there is a route out to the right on the algorithm to consider PTH replacement therapy. So that would be in those patients who it's impossible to achieve eukalcemia with conventional therapy, that their phosphate remains high, that their magnesium remains low. And in the bottom panel, highlighted in blue, and I'll read these out because I think these are important, is indications would be frequent fluctuations in calcium levels or symptomatic hypocalcemia, impaired quality of life, attributable to chronic hypoparathyroidism. We can discuss that if we wish. It's a tricky one. Reduced kidney function with an eGFR less than 60, hypercalciuria defined by reference ranges, or hyperphosphatemia. And if patients access PTH replacement therapy, we recommend reassessment at 6 to 12 months, particularly perhaps around the quality of life, because if somebody has some issues with quality of life, you start them on PTH replacement therapy, you haven't impacted that at all, then it's difficult to make a case for continuing PTH replacement therapy. That would be unusual, but that's the reason that that's mentioned. So that's just a whirlwind to set the scene. I think there are copies of the paper around, and I know Jens is going to give a fuller presentation after this, I think, around the guidelines, and Jens led us through this guideline group. So in summary, what the guideline does, it provides a holistic, not just look at the calcium doctor type of approach to managing hypoparathyroidism. The algorithm is complex and required many hours of many of us having input to try to make it as watertight as it can. Clear targets, both around calcium, but around primary and secondary targets, indications for accessing PTH replacement therapy, and also provide structured monitoring. So again, it's just to recognize that I'm representing a large group of individuals across Europe and with US representation as well. I hope you'd agree it's a helpful piece of work, particularly at the time that we're getting into the realms of PTH replacement therapy. Thank you for your time.
Please. Thank you very much, Neil. Please have a seat. And now I will hand over the discussion for our colleagues. Please, Professor
Thank
Anna.
you, Neil, for this excellent talk. I'd like to ask you regarding the renal complications, and since the renal ultrasound is no longer used as a routine, how do you, in clinical practice, how do you follow these patients and which periodicity, how we should do it? Thank you.
Yeah, sure, and I hope it doesn't come over that not imaging the renal tract means that we shouldn't be thinking about it, because renal dysfunction as a potential long-term complication is really important. So monitoring renal function as well as the calcium and the phosphate, and in the guideline we suggest every 3 to 6 months, but I think that depends upon the degree of stability. And the other factor as well is making sure that the patient is informed as to if you experience these type of symptoms, particularly around renal stone disease, then that would be a parameter to metaphorically raise their hand so that they would come to you with that. Of course, measuring urine calcium excretion. So I think if you see step changes, in other words, despite everything else looking stable, you see some perturbation in renal function, either clinically through symptomatology or biochemically, that to me, I would have a low threshold for imaging the renal tract.
Okay, thank you.
Okay.
Yeah.
Thank you, Professor Neil. It's always a pleasure to hear you. I would like to take advantage of your expertise and focusing on active vitamin D, like in the guidelines, as the major thing that you should use to use conventional treatment in hypo-PT. You told us that about 2/3 of your patients with hypo-PT are not using calcium supplements. And I think this is a reality that's a bit different from the Portuguese one. So my question would be, in clinical practice, how do you do it? Let's say you have a mild hypocalcemic, mild hyposymptomatic patient, and you uptitrate active vitamin D. Are phosphate levels the major factor that limit getting to the higher dose? How do you do? How long do you wait to see if you can manage patients only with active vitamin D? How do you do it?
Yeah, it's a great practical question, and I think most of that depends on who gets hold of the patient first. If I get hold of the patient first, I will go with predominantly alpha-calcidol, but we sometimes use calcitriol. And I will try hard, I will talk to the patient about dietary calcium, and if I'm convinced, or if they use a calcium calculator online and their calcium intake is reasonable, I will persist with alpha-calcidol up titration. If I get to when I get to a point, it's usually that the patient will say, you know, most of the time I'm okay, but if I go for a long walk or if I go for a run, I do get some twitching, tingling, and numbness. So I'll always say, have some calcium in your back pocket or in the cabinet, so that perhaps before you have take that exercise, to have 500 milligrams or a gram of calcium to try to stave that off. So that's very practical. If I receive patients post-operatively that the surgeons have got their hands on, they're the ones that literally do come to me on 6 grams of calcium, and of course the patients have already bought into the fact that it's all about calcium, doctor. So there's quite a difficult message around, work with me, let's see if we can lose that calcium and let's up-titrate the vitamin D. And it doesn't always work that you get to the calciums off the scene and you've achieved this, you know, magical dose of active vitamin D. But usually the patients are so relieved to be told that it's not all about the calcium. You know, the number of people that come in my direction just being miserable through predominantly GI issues, you know, maybe the typical constipation, maybe overflow diarrhea, but you can make massive impacts on symptomatology by having either just a sensible low dose of calcium or no calcium. And there was a publication a few years ago, and I think it was Clinical Endocrinology from the UK, with the patient support group supported by endocrinologists. And basically the patient voice is saying, if we don't need calcium, we don't want to take it. We don't like it. It makes us feel miserable. So I think we feel empowered, and I feel empowered to try my best to move it off the scene, but not at all costs, not at all costs. The phosphate, I think phosphate is really tricky, you know, and the guideline is really very clear on this. And I think in practice, I feel that I can do a better job with the calcium and the symptoms. I don't very often do a good job with the phosphate when I'm using just standard conventional therapy. And that, you know, in the future maybe, as hopefully access to PTH replacement therapy comes along, you know, that could be a solution.
Okay. Thank you very much, Neil. Now we are moving to the audience. If we have time, we'll come back to you for another round of questions. Is there... Yes, Dr. Jorge?
Thank you for excellent communication. In your practice in UK, how about the patients that are taking a lot of pump inhibitors that decrease the absorption of calcium? I agree with Miguel, because when we have a little bit higher the phosphate, if we only increase the dose of active vitamin D, we are going to increase phosphate, and the calcium, because they are taking pump inhibitors, and we have a lot of chronic gastric atrophy, could be a problem.
Yeah, again, a really practical point. And I suppose there's a couple of things. The role of calcium citrate, which we know is acceptable in the setting. We don't need an acidic environment in terms of absorption. And I'm also aware that it's difficult in terms of prescribing calcium citrate, etc. But I think that is a potential way forward. But to me, I suppose the fundamental question is, when we're managing the patient and the guideline tries to look at the patient holistically, how hard do we try as endocrinologists to make the numbers right, and at what cost to the patient? So I would say I would prefer to have a happy patient whose phosphate's a little bit high than an unhappy patient with abdominal pain on lots of calcium whose phosphate's okay. And that's the tension, I think, in clinical practice, and where I started from with the previous guidelines and how you can adhere to them. I don't think we have the tools in the bag to provide the optimal care. And the relevance of the guideline is we're at the point where I think we have got something that will allow us to get the win-win, because I absolutely take your point. You can't win everywhere with conventional therapy, or you can rarely do that in patients that have any degree of complexity. Because with these patients, if you can't get them sorted early on, my experience is you very rarely can using conventional therapy. But I absolutely take your point.
Thank you. Is there any further question? Yes, please.
Thank you for your presentation. Usually I don't see an increase on phosphate when I give calcitriol to our patients. And actually I would want to ask you if FGF23 could have any role decreasing phosphate instead of increasing after calcitriol. And I don't know if you measure FGF23 in these patients, because I think it could be a good explanation for that. And another question is regarding BMD. If the patient has osteoporosis, how do you treat these patients? With antiresorptive or not? Is a quick question.
Yeah, I wish I could give you a quick answer on that. That's a really tricky area. Regarding the phosphate and FGF, I don't know what the FGF23 levels are in hypopara. I don't know if anybody does. But of course we know the mechanism with PTH
maybe it's high. I think it's high because phosphate is low, very low, I think.
Yeah, but we know that
phosphate
it's
high.
The role of the PTH and its actions in the renal tubules will be driving it primarily. Bone, it's really tricky. I think there isn't a standard answer there. I personally, I feel nervous if I have a patient with chronic hypoparathyroidism, if their bone density is low, and we know that that's a low turnover state, to add an anti-resorptive would make me feel very uncomfortable.
Yes, me
and
too.
I'm not sure if I can say much more than that. But and again, I suppose if we, perhaps straying into what Ellen is going to be talking about, but we know that you can make bones physiological by adding back the PTH. You have this transient rise in turnover markers, this transient reduction in bone density and then stability. So I think for us to both understand and manage bones, it's really difficult to see how we can do that with our bag of conventional therapy. But yeah, tricky question. I don't know the answer.
Thank you.
Can I just add something? And as this subject about bone, the panel does not recommend DEXA, at least just in the general population, right? But we know for some studies that these patients can have more fractures. So how the panel does not think we could follow these patients in another way, for instance, regarding the fractures, what do you think?
Sure. So I think if we made bone density scanning a routine part of care of hypoparathyroidism, I think there could be the unintended consequences of making people feel comfortable that there's nothing wrong with these people's bones because their T-scores are very positive, which of course is not the story. And we know that this is more of a bone quality, bone microarchitectural, bones are asleep, and things like perhaps TBS and QCT that give us better understanding of the microarchitecture would give us the parameters that we need. So I think to do a test out of context, it could provide misinformation. We're in the era of misinformation, aren't we? It could provide us with misinformation and make us feel confident when we shouldn't. We should still be concerned about fracture risk, but as you say, we're not quite sure which types of fractures in patient groups. Probably increase in vertebral fractures, but do we have the tools to unpick that if we don't use PTH therapy? I'm not sure we do.
Okay.
We still have time for one quick question. Okay, thank you.
Good afternoon, Dr. Neil. I would like to know which is the maximum daily dose of activated vitamin D that you use before you start calcium supplements.
I hope I haven't conveyed that it's all very simple in my practice, because it's not. In terms of practical dose, if I have a patient taking certainly, let's say, 4 micrograms of alpha calcidol, they will very likely be taking calcium as well. In other words, I'm trying very hard with the doses I can to achieve an appropriate level of calcium. I think in terms of that dose and calciumic effect curve, once you get to around 6 micrograms of alpha calcidol, you're running out of steam. You're not going to get much more of a calciumic effect. And again, practically, if I get to that level, particularly if I don't have access to PTH replacement therapy, I often switch, if the patient's on alpha calcidol, I would switch to calcitriol because of the double potency. So again, this is more just an experiential thing. I will try to push a little bit harder with the calcitriol. And again, I don't know what other people think. Some people seem to respond better to alpha calcidol or calcitriol, so I think it's worthwhile switching. But where we are in time, I hope we get to a point where all of this nuanced practice that we're trying hard with conventional therapy and we're not winning, that there may be a point in time when we've got something else to try. In the UK, we're not there yet. We don't have access to PTH replacement therapy.
Thank you, Neil, for your sharp punctuality. We still have 2 minutes if you want a question.
May I a quick one?
2 minutes.
Another practical question is about managing hypercalciuria. We do have a problem, and to give some context, in Portugal we have a median intake of sodium chloride between 11 and 12 grams a day. So you have a high sodium chloride intake. I know that you are not a big fan of thiazides as a weapon to deal with hypercalciuria. So in practical terms, how should we manage with conventional treatment hypercalciuria, Professor Neil?
Again, I think it is very difficult. There are those patients that have disproportionate hypercalciuria, compared to what they tend to run in terms of serum calcium. Practically, I suppose I think as well of what is it I'm trying to prevent. So predominantly, I would say stone disease. So I would be emphasizing the importance of hydration status as well. I would try to be working on the sodium element in somebody with a high sodium diet. And I do try thiazides. I must admit, I don't want to be dismissive of that. But my experience is quite unhelpful with thiazides, that if you have somebody with a very elevated degree of hypercalciuria, you may be able to reduce that very elevated level, but still, you're, in my experience, unlikely to be able to pull them into the reference range. So, and I think a lot of these questions, it demonstrates a wicked problem that we're all confronted with. These things, these parameters that we know should be beneficial to prevent long-term consequences, that we just can't get that balance right in a substantial, probable minority of patients. So I would go through exactly what the guidelines say, but it's that realism of, is this going to achieve what we wish it to? And again, I might be heading right on the algorithm with these kind of patients.
Thank you very much, Neil. Perfect. Punctual to the second. So the next speaker is Elena Tsurdi. Please, the floor is yours, Elena.